Hello, my name is Dr. Adam Cole. I'm an anatomic and clinical pathologist. I'm also the Chief Science Officer and founder of TruCore Pathology Group, and I'm a colonel in the Air Force. Now, I know what you're thinking. We might as well address the elephant in the room. You're saying he's a colonel in the Air Force, and what's up with that hair? And you're not wrong. It's out of regs. I am, at this point, I would say hippie adjacent. If you're in another service branch, I'm sure the Navy, Marines, Army, right now you're looking at it and shaking your head and saying, yep, Air Force standard. I'll take that shot. I will get that fixed ASAP. That being said, what are we here to talk about today? It's honestly, why should you care as a urologist whether your pathology report is generated via digital pathology or traditional, more analog, i.e. microscope? In the past, it really hasn't mattered, but that's changing rapidly, and I'm here to talk to you about why. So we've partnered with a company called Lumea out of Lehi, Utah, and really trying to revolutionize from start to finish how genitourinary pathology is being practiced. So in lieu of having those 12 formalin-filled containers that your nurse or MA would have to handwrite the patient's name, date of birth, and location, we use these biopsy boards in your upper left-hand corner. They come pre-labeled. Now this is for a truss biopsy, but we also have transperineal templates as well. There's 6 channels cut into this. It's a little bigger than a deck of cards. There's a formalin-filled sponge at the bottom. And what happens is during the biopsy, you lay the needle gun in. It can only go in one direction, twist your wrist, and the tissue comes off. Gives you immediate feedback as far as the quality of the core, but it's also, for the first time, provides us the opportunity to maintain orientation through processing of that core. So we know if there's cancer, where within that core is the cancer? Is it deeper into the prostate, or is it abutting that pseudocapsular surface that we feel you may find useful when it comes to deciding if a patient would be a good candidate for nerve sparing if radical is the way they choose? On the back of this biopsy board, there is an RFID tag. At time of biopsy, you just have to scan that tag, put it in the patient's information, and then forevermore, we will now know where that tissue belongs, which patient that tissue belongs to. At the end of the case, there's a lid that fits on top of this biopsy board, and it seats that tissue down into these channels, and then you ship it off to our lab in Little Rock, Arkansas. Now, because the tissue is being pressed into these sponges, it prevents fragmentation. The tissue's not being agitated during transport like it would in traditional methodology, which affords me the opportunity as a pathologist to see about 15 to 20% more tissue. Once it gets to our lab, our histotechs will take that tissue out of the channel. It will load it into what we call a biopsy chip. It's basically a miniature version of this. It's made out of a bioidentical gel, seats that in there, again, maintaining orientation. We bury the RFID chip underneath it, and it would be processed like it would any other prostate biopsy. At the end of the case, we've got the entire right side or entire left side on a single slide. Those slides are then immediately whole slide imaged so that I can gain access to that tissue via our laboratory information system or image viewer. Now, in contrast, in the past, you would have 12 slides versus the 2. I'll explain why that's important in just a second. Once it's up in the cloud and I'm able to take a look at it, this is an example of what I look at as a pathologist. On my iPad, I will start scrolling through the tissue and I'll circle the areas that are cancer. I real-time grade it, and then the computer calculates exact tumor volume against core length. It's no longer an estimation by the pathologist. It also is building in the background that cartoon pictograph of exactly where that tumor is located within that core. As you can see, there's arrows pointing up. So this is that part of the tissue that is closest to the pseudocapsular surface. This is the deepest part of the needle. Now, if it's cancer, no need to go further. But if it's benign or atypical, in the past, when we had 12 slides, I couldn't run an immunostain on all 12. I would have to cherry pick the ones that I'm most worried about and order an immunostain on those just to further interrogate that tissue to make sure there's not a really well-differentiated cancer that I'm just overlooking. Well, the way we work is when I order an immunostain on a negative or an atypical looking case, Sure, it hits that core, but that antibody cocktail flows over the entire left or right side of the prostate. Now, I don't charge the patient for all of those, but it's an opportunity for me to get 1 second look at the prostate tissue to make sure nothing has been missed. Lastly, now that it's a digital image, I'm able to utilize artificial intelligence just as a second set of digital eyes, as a safety net, if you will, to make sure nothing was overlooked. And I'll dive into that in just a second. But you combine all of these things, whether it's the tissue preservation piece, utilizing the biopsy board, the immunostaining, the efficacious use of the immunostaining, or the addition of the artificial intelligence, and it drives our national cancer detection rates up to what we believe are the highest in the country, anywhere from 61 to 64%. Okay, so now what does the artificial intelligence look like? Well, this is an example of a case I would have. Like I mentioned, I would immediately go through and start circling the areas and Gleason grading those as far as what I think they are. And at the end of the case, I'll hit this little button up here and it gives me, again, the AI will take a look and make sure I haven't missed anything. So it's highlighting things that it perceives are worrisome for cancer. The blue it thinks is low-grade cancer. The magenta it thinks is more aggressive cancer. So drilling down on that, taking a little closer look, it does a pretty good job. It identifies, right now it's highlighting areas that I would consider poorly formed subset pattern 4 in the magenta, maybe some fusiform, versus the blue is grade group 1 or Gleason grade 3 disease. So that's where we are right now from a diagnostic artificial intelligence piece, but that's not where no one's comfortable staying there. So we're moving into the predictive and the prognostic artificial intelligence space. And so what does that look like? This was taken, it's obviously a heat map AI taken from a study we did with Tempest Labs out of Chicago. What it is looking for are things that I can't tease out with the naked eye, that it has been able to correlate with underlying rare pathogenic mutations, whether that's BRCA1, BRCA2, ATM, check, those kind of mutations that would qualify the patient for potentially a PARP inhibitor if needed. This one is actually looking at something called microsatellite instability high. So 2 ways that a patient would qualify for Pembro if needed. And that would be whether the tumor mutational burden is 10 or if they were harboring microsatellite instability high. I think we're quite a ways away from being able to label a patient with one of these mutations based on purely artificial intelligence interpretation. That being said, I think it's an excellent way to identify things outside the Gleason grading dogma that would portend either a more favorable or a more aggressive disease. So we intend to use the predictive and prognostic artificial intelligence to continue to advance the space on how do we become better stewards of the money we've been allocated and identify those patients who truly would benefit from deeper sequencing, whether that's somatic testing or germline testing. Okay, so what does our pathology report look like? It's a 2-page report meant to be seen in color. The second page is just patient focus. We strip away everything that's not clinically relevant. On the first page, however, it looks a lot like what you expect from a pathology report. Your patient demographics are on the top. Right below that, you've got your results summary. So in this case, 4 out of 16 cores were positive. It was a grade group 3, or i.e. 437. Perineural invasion was identified. However, there was no extraprostatic extension that we saw. Right below that is that critical comment. As you know, a lot of times the comments get buried at the bottom of a pathology report. We didn't want to do that. Not every pathology report will have a critical comment, but if there's something that we see as pathologists that we think you will find is clinically relevant, that's where we're going to fat finger that in. So what's included in that? Well, phenotype of pattern 4 disease. Obviously, if there's cribriforming disease present, that's a big deal. But it's not restricted just to cribriforming. If there's a pronounced desmoplastic response or there's increased tumor friability, both of those lie outside of the Gleason grading dogma. That being said, we know they play a clinical role as far as disease progression. So we'll put that stuff right there in that critical comment, but this is also where we will tell you as the urologist, if we have worked collaboratively together to help streamline your genomic ordering process, this is where we will tell you if a genomic test was ordered or not ordered. What do I mean by the genomic process? Well, We work with our urologist, whether as a clinic level or all the way down to the individual urologist. We can custom tailor to identify which genomic test you prefer and in which setting, i.e., are you just using it to identify which patient is appropriate for active surveillance? Or do you want to broaden that out to use genomics to identify who would benefit from treatment intensification via the addition of ADT? The reason I think that's important is you may be using your genomics, again, purely within that active surveillance decision tree. And you may check, I want it on 336, 347. Well, let's say you've got a 347, 1 or 2 cores, 5–10%, but that 5 or 10% is comprised of large gland cribriforming disease. Well, we know that's associated with more aggressive disease behavior. The tumor has declared itself as being more aggressive. So the last thing we would want to do is order a really expensive genomic test, burn through tissue while we're doing it, and then God forbid that thing come back and say less aggressive. I've kind of painted you into a genomic corner where you now have to sit down and explain to the patient why we ordered this expensive test, and we're going to ignore the results. Now, if you want it on every patient and you see utility, we're Switzerland when it comes to these genomics. We work with all of the companies in a very collaborative fashion. We're happy to order whichever test you prefer in whichever subset. Right below that is what I was talking about from a grid standpoint, where all the individual core results are. You can see this is the cartoon I was talking about. The capsule's located on the left-hand side. The deepest part of the needle is located on the right-hand side. So, when it comes to apex or lateral apex biopsies, if you see all the tumors abutting that pseudocapsular surface, whether I've said there's extra prostatic extension or not, you may want to include that data set into your decision as far as nerve sparing. If you give us a clinical T-stage and a PSA, then we can include a Hand and Parton table as well. So that's about all I've got as far as talking about the differences between digital pathology versus traditional analog pathology. There's no doubt about it. It's a better mousetrap when it comes to not just the identification of prostate cancer, but the quantification of the prostate cancer. And as we move forward, we think it's going to really play dividends when it comes to identifying which patients would benefit from deeper genomics. Thank you for your time. Please visit us at our website, www.TruCorePath.com, for more information. Thank you.